right, we'll get started. Thanks everyone for joining us this morning. Hope you guys are having a wonderful time at HIMSS. My name is Rohit Shinde, and with me I have Scott Ogden and Ravi. We all are going to talk about the work we have been doing, part of the HL7 Vinci project, which is focused on advancing interoperability in the payer-provider value-based care space. So again, we are accelerating different user implementation guides or IGs or use cases. And today we are going to talk about one of the IGs which is very important to reduce provider burden when it comes to reporting supplemental data back to health plans required for treatment, payment, and operations use case. So here we go. Thank you. So we'll start off why the journey as to like why we as a vendor found the value of investing in advancing this framework. As we all know, data resides in different silos in all aspects of healthcare, not just on the health plan side, the provider side, you have the health systems, HIEs, private networks, pharma data, everywhere, right? And as we move from fee for service to value based care, we had to support a unified language we can plug and play with multiple sources, because when we go to any health system today, they accept multiple insurances, right? And same thing as a health plan, they communicate with multiple providers. They could be using multiple different types of EHR platforms. So how do we bridge that gap where we can build once and deploy multiple times, where each implementation is not a new development, right? It's basically just a configuration and you can turn on the endpoint to be live and exchange the data. So those were like the main reason for us to standardize using a standard that didn't exist previously in the industry. So thanks to HL7 and CMS and the Vinci project team, we were able to get together with industry leaders, identify how we can leverage FHIR specification to solve that problem. And I'm happy to say that this use case is now live with hundreds of providers who are now seamlessly sending data back to the health plan, reducing the time they are doing with HEDIS chart abstraction, work they have to do for different spreadsheets or portals where they have to go and enter the data again. So it's accurate data that is being sent in a timely manner between the provider groups on the right side of your screen back to the health plan who is on the left side of the screen. So the way we architected this is basically through a secure cloud-based service where we deployed APIs for member matching and record locator services. So we know that member roster that we are looking for, which practices they belong to. And for those members where we found the data, that is now sent in FHIR format back to the payer for ingestion. So once it hits the payer backend, Scott will talk more about how they are working with it. We even sat with the teams to understand what FHIR resources are more important today from a value-based care standpoint, right? We are talking about treatment, payment, and operations, all three scenarios. And again, we started with a core set of resources to get a minimal viable product online. And then we continue to expand these FHIR resources to include other data points that are important for those TPO use cases. I'll hand it over to Scott now. He can talk more from a payer perspective.
Good morning. Scott Ogden, Florida Blue, IT business architect. With me as well, I have Ravi Paladugu. He is our principal IT developer. Very proud to be here. Very happy with everything that we've accomplished over the last 4 or 5 years of building this up. It's been an evolution of work that has started off very, very small and has become very, very large in the scalability and in the opportunities that we're providing to both our providers and our patients. So we're going to move into how this is the clinical data exchange for the payer perspective and how this is really enhancing the opportunities that we have from starting with the IGs that we have in front of us and using it from a scalability perspective to enhance and go beyond and incorporate additional IGs to incorporate business value. So starting off with our vision, We started with the Da Vinci's Clinical Data Exchange IG that is built off of the Payer Data Exchange IG. So those being two separate IGs, we have worked to combine them into one synonymous process so that we can give the data back to our, give the clinical gaps and data over to our providers, and then they can send back the closure of that gap from a point of care perspective so that we can update our back-end systems so that we have a more overall longitudinal record, a big picture of the member care, and overall value-based care for our member. Now, what this also does is it promotes the provider to payer trust that we all know that there's a little bit of a wall there. We're trying to kind of break down those silos, break down those walls. This really helps incorporate and build that trust between the payers and the provider to ultimately give much better care to our patients. And as Rohit also mentioned, I mean, if you take up all the HEDIS measures, the risk assessments, the star ratings, all the things that we see from a performance and profitability perspective, this really puts us into a much better spot. So some of the objectives we tried to accomplish is we wanted to enable an OAuth connection with our EMR. So again, it starts with our PDex process. As most of you know, PDex is the data we are giving back to the EMR so that the EMR can build a solid picture for the patient of what the care is needed, what are their gaps in care, what are their point of care alerts, what is the longitudinal data that we currently have at the current state. Then once they are able to execute that care, they're able to send back the CDex bundle, which maps back to our payer data exchange references so that we can close those gaps in care. So again, like I said, it's going to promote that provider-payer trust, and it's going to increase all of our performance for HEDIS, risk assessment, and star ratings. So this is a snapshot of our basic architecture. I'm not going to go through this, this very detailed document, but you can see from a general perspective that the technology, it works and it speaks for itself. You have your EHR that's going to work through its identity access management. It's going to go through our API portals. It is a FHIR-enabled connection, so it's going to go through our FHIR bridge and maps and store down into our FHIR repository. Subsequently, we have a gaps in care service, so it's going to continuously feed and update our gaps in care database, which then has the closure of the soft and hard gaps. So from a conversational perspective, we did want to ask each other a few questions. So I'm going to ask Rohit a few questions here. How did HELow Insights handle evolving FHIR standards? And did you face any challenges?
Yeah, no, it's a great thing because as everybody translates data from traditional silos to normalized FHIR facades, it is a journey, right? We all learned the hard way that some of the formats were easy to convert. Some of the data sources were more advanced compatibility with FHIR version 1 as well as R4. Others, we had to work in phases to implement what we could get first and then expand on those use cases. And again, it's like Da Vinci project is a perfect platform where we could do that successfully because you don't just have IT and architects who can be great at solving problems, but you also have business folks guiding what is required, right? What makes the most impact? What is the need of the hour? What exists today versus where are the gaps that need to be solved out of the box? So we were able to do that using condition resources or other like the USCDI payload. So yeah, I mean, we did have to solve some of those challenges, but I think being part of the Da Vinci project, it really accelerated that solutioning work. Had it been like a point-to-point connection, it would have like probably taken twice as much time.
All right, so are you working on adding any new resources and capabilities in your CDex solution?
Yeah, I mean, we just got started, so I don't think there is a finish line we have defined because, I mean, we are talking to everybody. The burden reduction is real, right? So yes, one step at a time where we said, okay, first use case is empower the provider at the point of care. Now eliminate the data reporting overhead that practices have. So CDex is there. We are already working on others like medical prior authorization, member attribution, IG, where as a payer you can assign a member cohort to the practice. We are providing notifications IG where hospital discharges can now go into the point of care in real time. So again, we are just getting started, and I really see a lot of provider burden, provider satisfaction, and then intangibly member outcomes be treated by these. So yeah, absolutely. We keep adding more resources for medical prior auth. We keep adding more resources for ADT notification and other things.
Okay. Thanks. And one final question here is, how did Helo Insights decide which FHIR resources to include in your CDex bundle?
Yeah, so we worked with our business teams from the payer side. So risk adjustment departments, quality departments, I think those were the key ones. Because in the end, 96% of the health plans in the country have to report this back to NCQA for their quality star ratings, right? So I think it was along the HEDIS guidelines or HEDIS measure standards, we identified what are the hybrid measures that we can use clinical data. We don't have to rely on claims based all the time. And same thing from a risk adjustment standpoint, we worked with them to understand, like we are all evolving from V24 to V28 on the HCC model. Some of the Medicaid plans that we have in different states now use the CDPS model for risk stratification. So we had to make sure that we are not just bringing ICD-10 codes, but we are bringing all the respective data that will help them with a risk adjustment audit. So I think there were those business strategies and guidance that we got from the payer business teams to identify from a technology standpoint what is a must have versus a good to have. Yeah, and we continue to add to that.
Okay.
So you asked me some questions, so I guess it's my turn to give back to you some questions on of what we are thinking, and I think many of you in the audience may correlate to these. So feel free to stop afterwards and ask your questions. But Scott, as a health plan, right? I mean, we know data security, data privacy is at the forefront for everything what you do. So what type of security hurdles you have to overcome to enable a FHIR connection?
I'll let Ravi answer this one.
Stand head over
Thank you,
heels,
Scott.
Ravi.
We have legacy security protocols like MTLS. We are enabled that on data power, but MTLS enables only validates authentication authorization only on client server. But when it comes to FHIR, we need to give individual resource access. That's why we enable OAuth, and we bought a ForgeRock, that is our authorization server. With that, we enable the resource-based access mechanism for the pay members. And for coming to OAuth, we have multiple flavors will be there, like authorization code and client credentials. But here for CDex connection, which is a B2B connection, that's why we used client credentials in OAuth.
Ravi.
No, that's great. In terms of the next question I had was like, once this pipeline was enabled and data started to come back in, how did you work with your downstream business partners to take advantage of this data? Because in the past, some of them had their own department specific solutions. So now that this is coming into your main data lake, how is this helping everybody on the back end?
So that fantastic. What we're working through is kind of breaking down some of the old world. A lot of our old world is going into the old platform and the old data sources, and we're trying to enable new internal FHIR connections. So with that, we are exposing new URLs. We are propping up our business partners to have innovative solutions so they can explore the data in new ways that they never even knew they could. Again, it'll enhance the quality that we provide for care to our patients, the data that we give back to our providers. It also opens doors and avenues to work with new vendors for new solutions. There's so many solutions out there and capabilities out there that in the old world, we didn't even know existed. But because of all the FHIR-enabled standardization and the capabilities that we have, it enhances so much of that connection. Again, there is obviously some monetary capability there for the stars ratings and the reimbursements and the risk assessment and risk adjustment. So much capability there. And as we move further down the road, we're going to be enhancing our quality measures and our DEQM. So there's so much opportunity from the business value that we can offer moving from the old to the new in this new scalable standardization.
That's great. And I think all the bright minds and the enthusiasm that we have in the conference here, like this whole week, right? We have seen its industry in healthcare as we move and adopt new technologies, new formats, new interoperability standards. It takes a while to get adopted. So with the version 1.0 of CDex, which came out of the box, did you have to make any tweaks to it to meet business requirements?
Yes. So the original CDex integration, if you go out to the IG and you look at it, it essentially props it up to where the payer can query the provider. Kind of end of story, really. So what we did is we took that to the nth degree, and we integrated it into our PDEX model. And by integrating it into our PDEX model, we're able to directly associate the gaps in care that we're giving back to the providers via the EMR so that they can close and execute on that care, and then asynchronously send back to us the data that actually closes that gap so that we can have a long runway of the longitudinal record. So again, it brings it into much more of a finite solution to give a direct access, a direct integration of care for our provider beyond what the original IG is. And so that's one of the things we've really learned as we've enabled this FHIR standardization. The IG is out there to help you start, but it's not the end all be all. You have solutions you can build off of the IG and work it into your business model of whatever you are doing, whether you're a payer, an EMR, whatever it may be. So it goes well beyond all of that.
Yeah, no, I think those are some of the great lessons learned, and we are happy to share our additional journeys or additional lessons learned to the folks in the audience. So feel free to stop by, ask questions. I'll be at our booth also, and looking forward to having some interactive conversation. With this, we'll open up for questions. Any questions in the audience for now? Yes, sir.
Thank you. So I had a question on the gaps. First of all, were people actually paying attention to those? And also, who did you communicate it to? Because a lot of times in those measures, it doesn't have to be the PCP. It could be a specialist that closed the gap. So did you send that to everyone? And then are these capitated patients in this pilot, or is this something broader than a pilot?
No, I mean, that's a great question. So the question was like how folks are paying attention to this. So yes, it's firstly for all lines of business, because that's one of the main thing provider groups want to do is have normalcy in what they are seeing for every member they treat that day. So if I'm a primary care physician and seeing 20 patients a day, I would love to get payer data for all those members if like they belong to 5 different health plans. So that's one of the value add for providers. And in fact, the care gaps are, I would say, more valued by the specialists in some cases when we talk to them, because I'm an orthopod, I'm prescribing a steroid to Rohit for his joint pain, not knowing that there are some other conditions that Rohit has, right? And those care gaps, coding gaps help them. Now, they may not really close them, but it's giving them a perspective of what treatment plan they do. And then more on the primary care side, where today, if you ask anybody, it's 50-50 between value-based care and fee-for-service, or like full risk type of arrangement. So we are seeing pretty much payers are able to send this for all lines of business: commercial, Medicare Advantage, Medicaid, and so on and so forth. So with one of the largest Medicaid plan in the country, I won't take the name, but they were able to see 98% engagement from the practices that they deployed this to. And again, every clinic has a defined role, whether it's a small practice or a large hospital system, you have roles that do this, like a care manager, case manager, a nursing pod. So it doesn't have to always be the physician who is looking at it. Many clinics we talk to today and work with, they have a workflow for pre-visit planning, and they are able to preload some of these things part of like 2 days before the appointment or the day of appointment. They prepare these charts and have these care gaps and everything configured so that when the provider sees the member, they're like, yep, let this order be sent out now. Hope that answers your question. Yes, because these are same in HEDIS quality vocabulary. So you have your colonoscopy overdue, or patient is overdue for their dental visit. They have not had that, or vision test is not done. So yeah, these are like we use the same HEDIS vocabulary, so they are able to correlate to that. That's a great question. Yeah.
Any other questions, feel free to come speak to us after, since we've reached time here. But thank you all for allowing us to be here. It's been
Thank you
great.
all.
Thank you.
Thanks for your time. Thanks, Scott.